lucky that I'm getting an opportunity to update stillbirth. I'll try to put it in a very, very simple language. And at the same time, in the end, I will try to do Cochrane review. What are the interventions which can be helpful, and what are the interventions which are not going to be helpful? Stillbirth is definitely poses a challenge there are many challenges in the field of stillbirth, and fresh possibilities always unfurl once we decide about training, training, and training. As for the India is concerned, in 2009, the stillbirth rate was 22 per thousand. It was 22 per thousand in 2009. While in 2021, stands at 12.4, with the range of 3.7 to 22.5, depending upon which state I'm talking about, per thousand births. So from 22, it has come down to 12.5. And what is the aim? Our aim is by 2030, it should be 10. And it seems that it will be doable. So I again repeat, the aim of stillbirth is to bring it down by 2030 as 10 per thousand, and we stand at 12.4. I'll talk about the definition, the epidemiology, the etiology, approach to the management, and approach to the management of subsequent pregnancy as well. Now, this slide shows you about the fetal death. Delivery of the fetus showing no signs of life irrespective of period of gestation, which is not induced termination. I think all terms are irrelevant to us in terms of stillbirth. The embryonic deaths are less than 12, the early are less than 20, and intermediate fetal deaths are less than 28, and later are over 28 weeks. But WHO says each country has to define the gestational age for reporting purposes. Term fetal death, fetal demise, stillbirth, stillborn are used interchangeably. And as far as the FOXI and the ACOJ are concerned, they recommend the term to be used as stillbirth. Fresh is whenever it has there's no sign of life and it has occurred within 12 hours, while macerated is one where the degeneration is present and it is more than 12 hours. Now, this particular slide compares what is the definition of stillbirth as far as the global criteria are concerned. As far India is concerned, birth weight of 1,000 gram or more, or 28 weeks period of gestation. And our aim is to come down to 10 per 1,000 by 2030. WHO says the birth weight of 1,000 plus. In case if it is not available, then gestation 28 weeks plus. And if that is also not available, crown heel length of 35 centimeter. Crown heel length of less than 35 centimeter. As far as America is concerned, they take a cutoff as 20 weeks and the baby weight of 350. And as for the England is concerned, it is 24 weeks. As far as the Canadian guidelines are concerned, it is again 20 weeks with birth weight of more than 500. Now, as for the epidemiology of stillbirth in our India is concerned, we will say that globally, in 2021, there are 2 million stillbirths globally. But if you take neonatal deaths, then it amounts to 3 million stillbirth and neonatal deaths. It means one stillbirth takes place every 16 seconds. In India, makes 17% of the global stillbirth. We have 3.4 lakhs of cases as a stillbirth. If it is divided by 20 lakhs, it will make to 17% of the global stillbirth. 50% are intrapartum, which is something very unfortunate, and 50% no cause is found. And as we all know that this is a problem of low and middle income group, and that's why 3/4 of the stillbirths occur in South Asia and Sub-Saharan Africa. In India, the stillbirth, I again repeat, it is 12 per 1,000 today. In the US, stillbirth rate stands around 2.95 per 1,000, and there has no change in the last 2 decades as far as the stillbirths are concerned. Why stillbirth is important? It is a devastating event for the parents, and gynecologists need to know for preventing stillbirths, they have to understand why it occurred and identify the preventable causes. And we also need to understand that you have to help the couple with the cope with the grief and plan for future pregnancy. These are the main causes. Multifactorial etiology as far as stillbirth is concerned: maternal, placental, fetal infections of both mother and fetus and unexplained. Mainly it revolves around placenta, fetus infections, and other things. You can see here causes in India and Southeast Asia are maternal are to the tune of 5 to 10%, fetal are 25 to 40% maximum. Placental are 20 to 35, and unexplained are 15 to 25. These are the maternal causes, and no cause is less important. In more developed countries, it is the obesity, where the BMI is more than 30, maternal age more than 35, chronic hypertension, diabetes, gestational diabetes. Substance abuse is also very important, along with the smoking. Previous IUGR in stillbirth, problem of HEPLA and autoimmune disorders, renal disease, hepatic cholestasis, jaundice, and thyroid. These are the various maternal causes which all of us are know and scared about. Now, as for these fetal conditions are concerned, whether there's a multiple gestation, or there's a growth retardation, or it is alloimmunization, or chromosomal abnormalities, or congenital malformation, the stillbirth rate becomes 4 times. In all these conditions, the stillbirth rate becomes 4 times. Now, as for the placental and the umbilical cord causes are concerned, we all know about the placental abruption and placenta previa, uteroplacental insufficiency in fetal growth retardation, placental pathology, and umbilical cord complications. Infections are very important. No infection is less important, but we all know that malaria in those areas where malaria is endemic is very, very important and not to be forgotten. Then in viral infections, CMV and parvovirus are very important. And as far as the bacterial infections are concerned, we all get at 35 weeks vaginal swab done for group B streptococci. Syphilis still occurs, may not be so much in metro because of the great screening. And here I just wish to also tell you about the flu. That should not be ignored, and that's why a vaccination against the flu also becomes important. Now, these are the transplacental route. You can see CMV, syphilis, parvovirus. All these things are they are transmitted by the placental route, including malaria. Ascending infections are which is there on the right hand side. Anything can go up the vagina. As far as unexplained stillbirths are concerned, they amount to 50% of the total stillbirths and not attributable to either fetal cause, maternal cause, placental, or obstetric etiology. They commonly are seen at term. I think all of us, the senior gynecologists, will remember it, that as far as the pregnancy loss is concerned, either it occurs before 12 weeks or after 28 weeks. As for the intrapartum cause of stillbirths are concerned, we all know that cord prolapse and vasa previa and placental abruption. So ye iska part hai, any emergency, these are the things can be created the emergency. As far as the obstructed labor, birth trauma, malpresentation, and all this can cause in presence of uterine contractions, uterine ruptures, and goes without saying, more the manipulation, the infection will take place. Now, coming to most important part of the etiology and its classification. There are many, many classifications of stillbirths, more than 30 classification. WHO stands international coding classification. This is for all diseases, not only for stillbirth. There's another classification which is called CODAC, causes of death and associated conditions. And this came in 2009, and then there is a recode classification, relevant conditions at death. This came in 2005. And this is what it is. Gardosi is the one who brought it first in 2006. It was first published. Fetus where there is a lethal congenital anomalies, infections, non-immune hydrops, isoimmunization, fetal maternal hemorrhage, complication of multiple pregnancies, and fetal growth retardation. Umbilical cord, we all know the prolapse, the constricted knot, the filamentous insertion, placenta, abruptio placenta, vasa previa, and other placental insufficiency. Amniotic fluid are chorioamnionitis, oligo, and polyhydramnias. A uterus can rupture, and it can rupture more so if there is a uterine anomalies. As for the maternal conditions are concerned, we all know about diabetes is known to cause stillbirth. So is the gestational diabetes. As for the metros are concerned, we find that stillbirth because of the gestation diabetes do not happen so much. But I think if you go back 2 decades earlier, there were a lot of stillbirths caused for gestational diabetes. And hypertension, hypertensive disorders in pregnancy, lupus, and cholestatic jaundice of pregnancy, drug misuse, all can cause stillbirth. Intrapartum are asphyxia and birth trauma, and trauma can be both external and nitrogenic, and unclassified is where no information we can gather. Then this gentleman, Gardosi, brought in 2016, amalgamation of WHO application of ICD-10 to death during the perinatal death. And he brought into 4 categories: antepartum, intrapartum, and neonatal, depending upon at what time the death has taken place. You can see the congenital malformation stands out in antepartum, intrapartum, and neonatal deaths. Infection, hypoxia is part of the antepartum deaths, because their majority of the deaths take place in the antepartum period. And during intrapartum period, it is acute intrapartum event. This can be because of the cord, it can be because of placental abruption, and or it can be because of the growth retarded fetus, which has a hypoxia. When the labor ensues, then not only there's a hypoxia, there's acidosis, and which kills the baby. In neonatal deaths, there are congenital malformations, disordered fetal growth, birth trauma, convulsions, and respiratory and cardiovascular disorders. All these causes are known to you. To us, it looks that every cause is there everywhere. As for the maternal conditions are concerned, maternal conditions are complication of placenta, cord, and membrane, which is the main thing. Maternal complication of pregnancy, other complications of labor and delivery, maternal and medical and surgical conditions, and no medical maternal conditions. These are the maternal conditions. As for the causes in India and developing countries are concerned, obstetric conditions are 30%, placental are 23%, fetal, that is genetic and structural, both are 14%. Infections are also something like 13 to 14%. Umbilical cord abnormalities cause deaths in 10% of cases. Hypertensive disorders of pregnancy cause 10%, and maternal medical conditions, including gestational diabetes, cause stillbirth in good 10% of cases. How do we approach a case of stillbirth? We establish a diagnosis, we need to counsel this patient, investigate the cause, then plan a delivery of this baby where the stillbirth has taken place, and management in subsequent pregnancy. The accurate diagnosis is she will say that she has not feeling fetal movements, but main thing comes from the ultrasound. And this again, to establish a diagnosis, you should not rush for CTG for auscultation. You should use ultrasound to confirm and establish the diagnosis of stillbirth. Sometimes mother may say that she can perceive fetal movements. You know it for sure that you have seen her through the ultrasound, but you have to again offer a repeat scan if passive fetal movements are felt by her. These are the impact of emotional reactions which can happen as a result of stillbirth, right from she's in a denial mode, and then there's a lot of anxiety, crying, and shock kind of a thing is there. She's angry and in disbelief. As for the counseling is concerned, it requires everybody can't do counseling. It requires a private space, both where you're doing a counseling, and you should have plenty of time. You should not be in a hurry when you counsel such patients. No specific cause is found in nearly 50% of cases, and this you need to put it across. And if the cause is found, we have to plan for the future pregnancy, and further investigations, if not necessary, if not done in this pregnancy, explain about the fetal autopsy, because fetal autopsy is the best. And complications of fetal death also you should know कि इसको how कितने दिन तक टाल सकते हैं. Investigation, as for the cause is concerned, you all know the history is going to reveal everything. Maternal investigation, then evaluation of the stillborn, fetal investigations, placental investigation, and if obvious cause is present, no further testing is required, like cord prolapse or anencephaly. In general physical examination, you need to see the mental state of a patient, vitals, systemic examination, and random examination. And the usual investigations are blood group, CBC, LFT, KFT, thyroid function test, and random blood sugar and HbA1c. Coagulation profile and DIC profile, urine, albumin, sugar, and ketones, ultrasound for fetal presentation, lie, placenta position, and for retained products of conception as well. Now, as far as the tests are concerned, they're all here. They're nothing new, which you do not know. Maternal well-being के लिए CBC, LFT, KFT, आपका CRP, DIC profile, and bile salts के लिए for ICP के लिए. Clay-Harbector test, we used to get it done in the side lab of the ward when we were getting MD trained, but now I find in any of the labs this particular test is not available. If anybody knows, please let us know how this particular test is to be done. I know it was very simple test and used to just take 5 minutes, but I don't remember anything how this Clay-Hart test is being done. And cultures are, you have to take whenever there is a prolonged fetal death for suspected infections, viral screen, syphilis, and tropical infections. You have to take to rule out diabetes, and thyroid function tests are also important. Now, as far as the investigating and evaluating the stillborn is concerned, the description of the stillborn baby is important for malformation, for skin staining of with meconium, degree of maceration, color, pale or plethoric. Umbilical cord, you have to see whether any of the problems like a prolapse had taken place, entanglement in the form of knot, hematoma or stricture, number of vessels present, and length of the umbilical cord. Amniotic fluid, prior to that, you have to see whether it was stained with meconium or blood, what was the volume, and membranes, whether stained or whether thickened. Placenta, again, one has to see the weight, the staining, the adherent knots, the structural abnormalities, filamentous insertion, edema, and hydropic changes. Now, as far as investigating placental and fetal conditions are concerned, these are very, very important. Fetal and placental microbiology, fetal blood can be taken up by the heart blood, and fetal swabs have to be taken, placental swabs have to be taken, and these are all for fetal infections. Then fetal and placental karyotyping. Here it is important that you should take the fetal skin 2 centimeter by 2 centimeters skin patch. Thickness has to be taken. Then fetal cartilage in case if it can be removed, and the placenta just below the insertion of the cord, you have to take the placenta of 1 centimeter, 1 inch by 1 inch, just below the cord insertion. And this these locations are very important for one has to do the detailed aneuploidy and a single gene disorder screening. As for the postmortem is very, very important. In case if it's not available, then anybody who can do an external evaluation of the fetus, the placenta, the cord, the membranes is very important. But autopsy can be absolutely great, and all of you probably know it, that it is live cells are uh, subjecting the autopsy for just 10,000 rupees, and they do it very beautifully. The reporting and everything is great. They send a container both for the placenta as well as for the baby. And goes without saying, the body should not be put in formalin unless you have taken out genetic testing has been done already. Now, as far as investigating the cause, autopsy, the gross and the histopathological examination of placenta, umbilical cord, fetal membranes by trained pathologists, the most important. If consent is not given for full autopsy of the baby, limited autopsy, one can get it done again on the request. As far as the cytogenetic analysis are concerned, the indications are if the child has congenital malformations, fetal growth retardation, non-immune hydrops, ambiguous genitalia, dysmorphic features in the baby, and the parent carrier of balanced chromosomal rearrangements. Now, at the time of diagnosis, one can do, when the baby is still not delivered, ultrasound scan, maternal blood test, maternal toxicology, maternal microbiology. After delivery, external examination of the fetus, infant blood test, microbiology, placenta, membrane, cord, histopathology, cytogenetic investigations, postmortem examination, and postmortem radiological imaging in case if they are refusing to do, give a signature for autopsy. Now you can see here what are the steps. First step is maternal and family history, where you have to sincerely give 5 to 10 minutes time. Then second step is maternal investigation. Then third step is stillbirth examination, that is physical examination, clinical photographs, radiological studies, autopsy, full or partial, and a trained person should do it. Step 4 is cord examination, baby cord examination, and then placental examination and investigations. And sixth is cytogenic investigations. I repeat again, the baby, the cord, the placenta, and the membranes are very, very important, and they will give you the biggest clue. Information used in counseling is no abnormality found, so you have to do empiric counseling. I did tell you that 50% you will not find the cause. And when abnormality is found, you will do a specific counseling. Now, labor कैसा होना चाहिए? उसमें previous history of delivery, any medical conditions, what is mother's preference, and the timing and the mode has to be decided. Now, for delivery, whether to induce or wait, or for both options, spontaneous onset of labor will occur in 80% in 2 weeks' time. Spontaneous onset of labor will occur in 80% in 2 weeks' time. Only 10% remain undelivered by 3 weeks, and delivery should not be delayed. In case if there is a ruptured membrane, there is abruption of placenta, preeclampsia, and sepsis. In these 4 conditions, please do not wait. Now, if patient decides to have unexpected treatment, the periodic follow-up is required for temperature, for bleeding, for pain in abdomen, chorioamnionitis evidence, emotional status of a patient. CBC and coagulation profile twice a week has to be done. CBC and coagulation profile twice a week has to be done, and 10% chance of maternal DIC within 4 weeks from date of fetal death is known. Now, what about the delivery mode? Mifepristone is the first line of management. It is given in the dose of 200 milligram 3 times a day for 48 hours. And you find that the labor occurs in good 65% of patients in comparison to 17% where mifepristone is not used. It doses 200 milligram 3 times a day for 48 hours. And then you'll find in 65% of patients, the labor ensues. As for the intravenous oxygen, oxytocin and vaginal misoprostol is concerned, vaginal misoprostol is more effective. The dosage is, if it is less than 27 weeks, it is 100 microgram 6 hourly. Or if it is more than 27, 28 weeks, it is 25 to 50 microgram 4 hourly for 24 hours. Cesarean delivery only for maternal indications. And delivery plan is patient health and obstetrical history and her preferences are very important. Now, as far as the delivery is concerned, if there is a sepsis, you will give a broad spectrum antibiotic. Otherwise, routine prophylaxis is not recommended. For pain, you can give her good sedation, pethidine or fotwinfinagan, and assess DIC and sepsis. And these patients all through require a good emotional and practical support. Post-delivery, patient and family is allowed to see and hold the baby. Grief counseling has to be done. Lactation suppression is required, and patient has to be also given contraception. Subsequent pregnancy after stillbirth, it is said that overall recurrence risk is increased 2 to 10-fold depending upon what is the underlying cause. And as for the counseling on prevention prediction is concerned, if it's an unexplained stillbirth between 20 to 37 weeks, in future also 1% cases it will be there. And unexplained stillbirth more than 37 weeks, you'll find again very small number may be there, but it can be there 2 per 1,000. As for the preterm and preterm delivery and fetal growth retardation had been there, again it is around 2%. Problems can be there. Probability in subsequent pregnancies is congenital malformations depends upon the type of anomaly. Abruption can repeat in 9 to 15%. Vasa previa and umbilical cord abnormalities remain undetermined. Turner's, again, it is sporadic. You can find in trisomy 21, 18, and 13, fuel mutation has to be present in 1 to 2%. Autosomal recessive disorders will present in 25% cases. X-linked disorders will only manifest in male offsprings. Infection will vary. Preeclampsia, again, there is a chance of repetition in good 14 to 15%. Diabetes, every case is a potential in future as well. And so is in thrombophilia, APLA, and isoimmunization. Now, what about the management in future pregnancy? Whenever patient comes, you see all our records again, discuss possible etiologies and workup, determine the recurrence rate, determine the medical and obstetrical history, optimize maternal and medical conditions, change potentially modifiable conditions like smoking, substance abuse, alcohol. ये तो सब बंद करा ही दिया जा सकते हैं. Weight loss in obese patient is important. Genetic counseling if family has a genetic condition and they require support and reassurance. In first trimester, second trimester, third trimester, your approach has to be more or less the same. In first trimester, you have to see to it that you do an ultrasound for proper dating. First trimester screening में dual test करेंगे और आपका NT-NB scan करेंगे. Diabetes screening, APLA, thrombophilia workup is also required, and they require tender love and care. While in second trimester, beside tender love and care, if the dual screen has been missed out, then she requires a quadruple screen, and a fetal anomaly scan has to be done around 18 to 20 weeks, again in detail. While in third trimester, beside the tender love and care, you have to see to it that the fetal growth retardation is ruled out. Patient has to be told about the daily fetal kick count starting from 28 weeks, and surveillance is required properly in 32 weeks onwards, and or 1 or 2 weeks earlier when the stillbirth had taken earlier in the last pregnancy. Delivery no risk factor, elective induction at 39 weeks as per medical indications, and avoid scheduled delivery before 39 weeks if the previous stillbirth is unexplained and the previous delivery is uncomplicated. Now here you can see that these patients require folic acid supplementation 2 months prior to this thing, prevention of malaria, and fetal growth retardation and management is very important. You must pick up fetal growth retardation, and they should not be allowed to go postterm. Hypertensive disorders and the diabetes must be picked up early, and the treatment should be instituted. Same is for syphilis detection and treatment. Delivery should be conducted by trained birth attendant. Basic emergency care should be available, and availability of comprehensive emergency obstetric care should be also available. So take-home messages are, in today's time, the stillbirth rate in India is 12 per thousand. Risk factors are if she's less than 15 years, more than 35 years, nulliparity, BMI is more than 30, smoking, multiple gestation, BOH, preterm, fetal growth retardation, and stillbirth. These are the risk factors. Each and every point is important. Age, the weight, the smoking part, multiple gestation, previous history, obstetrical history, preterm, fetal growth retardation, and stillbirth. Causes are obstetrical are 30%, placental are 24%, fetal genetic abnormalities in 12%, infection in 10%, hypertensive disorders and diabetes make around 10 to, both together make around 10 to 20%. No causes found in good 50% of cases. Most important part of evaluation is medical and obstetrical history. Gross and histopathological examination of placenta, umbilical cord, and fetal membranes by trained person is required, and fetal autopsy by trained pathologist is boon in such cases evaluation. Fetal maternal hemorrhage testing in all, again I'm trying to tell about the Klehar technique, chromosomal microarray, otherwise you can do indirect Coombs test. Chromosomal microarray first line testing cost is no issue, it is karna hai to karna hai. And APLA study, do it in all cases. Parents should see and hold the child, take a photograph, handprints, psychological counseling is all that is important. Subsequent pregnancy, serial ultrasound for fetal growth and surveillance, and elected delivery not later than 39 weeks. Each baby counts, and each one of us can make that difference for that particular lady and the baby. Now, few slides on the Cochrane review. This review has been done in 2020, and they reviewed 43 studies and 61 ways of intervention was there. They found that four things were very important. One was maternal nutrition. I did tell you that it is seen in low and middle income group, the stillbirth rate is the maximum. And they found that maternal nutrition had a clear benefit. And out of that maternal nutrition also, पहले तो total calories दो, वो आधा पेट उसका भूखा नहीं रहना चाहिए. And protein supplementation are very important. Total calories and protein supplementation very important. This will bring down the stillbirth rate by 40%, because this is required for fetal growth retardation को कम करने के लिए important है. And the risk factor in such patients is 0.67, which is less than 1, and 95% solid backing है इसके. Goes without saying that these patients require folic acid, iron, folic acid supplementation, zinc, vitamin and micronutrients. So इन सबसे पहले ज़्यादा चीजें important है कि उसकी calories पूरी हो और उसका protein supplementation पूरा होना चाहिए. Now, as far as the infections are concerned, prevention and management of infections are concerned, this itself can bring down the stillbirth rate by 33%. मलेरिया जिनके जगह पर मलेरिया है वहां कहते हैं कि सबसे ज्यादा जो फायदा है वो जो मलेरियल नेट है, if they are insecticide treated malarial net है, which this intervention is the maximum benefit patients को देता है. And otherwise chloroquine and hydrochloroquine can be used to decrease the incidence of active malaria in such cases. Syphilis, again screening. Torch is also very important. Every aspect of torch is important, and flu goes without saying that all these patients, wherever possible, you must give them a flu vaccination. Now, another intervention was if the delivery can be conducted by trained birth attendant, it brings down the stillbirth rate by 36%. Simple interventions. Community-based support to the pregnant patients. It is said that the government says 3 visits and WHO says 5 visits. According to them, antenatal visits close to term should not be decreased, because if the visits close to term are decreased, there are more stillbirths. So this intervention, this itself can decrease the stillbirth rate by 20%. They said that antenatal CTG can, if done properly, can bring down the stillbirth rate in good 80% of cases. And these ladies can be taught daily fetal movement count by any health workers. Screening for gestational diabetes, those were the days, when the stillbirths, because of the unpicked up gestational diabetes, were more. But now you find in your own practice, this sudden stillbirths have decreased markedly. The same way with hypertensive disorders of pregnancy, the two interventions, calcium in the dose of 1.2 to 2 grams, especially in a low and middle income group, the calcium supplementation should not be just 500 gram or 1 gram. It has to be good 1.5 to 2 grams. And aspirin has to be given is 150, and that also to be started prior to 16 weeks. And this can bring down to fetal growth retardation to in a very big way. Whenever there's a fetal growth retardation, delivery should not be delayed more than 37 weeks. Tobacco, alcohol, and substance abuse is quite significant, especially in India. And this can definitely cause stillbirth because of the decreased oxygen supply, and essential nutrients are not transferred to the baby, and there's a fetal growth retardation. Don't allow pregnancies to go post-term because we know that this allowing them to go post-term can cause placental insufficiency and increase perinatal mortality rate. It is said that the people who have periodontal disorders, they have more stillbirths. And a very interesting study I found yesterday, that even if you treat them with periodontal disorders, the stillbirth rate does not decrease. Fetal growth retardation, it has to be early. You should detect this baby is not having a proper weight, and this can be very easily done by symphysial fundal height and by Doppler, which can be umbilical, uterine, umbilical, and later the fetal blood vessels like MCA and ductus venosus. So I think, any questions?
Thanks, ma'am. It has been exhaustive and very self-descriptive, taking care of all the causes and all the interventions which can be possibly done to prevent a recurrence, which is very, very important. Now I'll invite the experts, Dr. Archana, for your comments. Unmute yourself, Dr. Archana, unmute yourself.
Thank you, Dr. Vandana. Dr. Sharda, ma'am, you just simply epitome of inspiration, that in spite of bad health, you are taking our classes and teaching everybody, and this is to be done because this is stillbirth is very challenging for the clinician and for the patient also, and so much of medical legal association with it, and how to handle the patient, and when you are diagnosed, when you diagnose, and then how to counsel and how to declare. So to declare the bad news, this is something very, very important, and then later on also, and postnatal care also, everything needs very, very empathetic and very, very simple way of management. The madam has already told how to wait for normal delivery or cesarean depending on the situation, and because this is something very challenging, and our aim is again, bookish knowledge is very, very different, but to manage and to diagnose is really needs a good mind and heart working together, and that is a main thing. And to show the that, and to diagnose the this work for the autopsy, and that those genetic causes, and telling them, and that is something very, very important. No other should say anything except the main clinical in charge, because they always want to know where what went wrong, when, and so that is something very, very important, and documentation also, and something. And and then how to suppress lactation, and how to tackle that storm of that anxiety attack of patient. So that is to be learned, and it's a practical approach, of course, and multidisciplinary action also, because don't even try to handle things all alone. So thank you, madam, thank you very much. Other
Thank you
this
very much.
expert will say, give other opinions.
Thank you, Dr. Archana, for your kind inputs. I'll invite Dr. Divya to give her expense.
Thank you, ma'am. Thank you, Dr. Sharda Jain, ma'am, for this exhaustive update on stillbirth. So I just want to repeat and highlight a couple of points. That's all. And the first thing is that an obstetrician needs to be knowledgeable, firm, caring, gentle, supportive, and as well as a Sherlock Holmes at the same time. As far as we private obstetricians are concerned, the ones who are in private practice, we need to take every antenatal case, I personally feel, as a high risk case. So as soon we are doing all the tests, of course, we're doing the NT-NV scan, the dual marker test, then we do the level 2 test, we're doing all the tests. And besides doing all the blood works, we must once again start doing TORCH, IgM and IgG both, because there is always a controversy, kare na kare, but I think it should be done, because ultimately when we land up with a stillbirth or a very early or a late IUGR, the first thing the ultrasound sonologist only or some other doctor or the pediatrician tells the patient, aapka torch hua tha ki nahi. So therefore, that is one thing. And then the next thing is that coming to 28 weeks, madam told us in one of the very early webinars, 28 and 30 weeks ke beech mein we must get an antenatal ultrasound along with a color Doppler that time. So we have a basic color Doppler at 29, 30 weeks, which, puts our antennas up in case there is a growing IUGR or not. And it tells us, about, of course, about many other things, about the amount of liquor and other things. Also, from 28 weeks onwards, we must start getting an ultrasound done every month. And we must also get CTGs done, if not weekly, at least bi-weekly. And we must also start telling her about the daily fetal movement count. I'm just repeating whatever ma'am has said. The other thing is very important, is that which we have never been taught, is the psychological management. So it is a management in itself. So right from the time when, when we put our fetal heart Doppler and we do not perceive any heart rate, and the patient also tells us she has no movements, then we take the patient for the ultrasound ourselves, hold her hand, and then break the news. That too in a very personal way. All our staff needs to be at once told to be very, very supportive. They move around in a very suspicious way, as if, it was the fault of the obstetrician, bahut bada koi galti ho gayi hai. So it is not our fault. We have to make that also very clear. Documentation, consent taking, and communication with the patient, all these medical legal aspects have to be followed simultaneously. And everything right from आप fetal autopsy कराओगे क्या, और वो अगर refuse करते हैं, that has to be documented. And if they don't want an autopsy, like ma'am said, MRI करो उसके patient, fetal ultrasound करो, उसकी genetic testing करो, placenta में कहाँ से chromosomal analysis के लिए material लेना है, and all the swab testing, everything needs to be done. So psychological support, it is not just a support, it is a management in itself. We should not fail in this context, because we are doctors as well as we are very, very caring doctors. And this profession needs to be handled in such a way. Thank you so much, Vanna.
Thank you, Dr. Divya.
I wish to just tell you, at 28 weeks, Doppler is not required. You require an ultrasound to know, whether because till 28 weeks, you
So around
deviation will start only after 28 weeks. So that time you must know whether the weight of the baby is the same like any other baby. Doppler is required after 54 weeks.
Right, ma'am. Or an early Doppler, just to that is done when the patient is between 12 to 16 weeks of pregnancy, to see for potential FGR and indication of potential FGR or hypertensive disorders of pregnancy.
Yeah, that is the time when the PI
that is very early. That is very early. That would not count in stillbirth, no? Yeah, that is very early. Dr. Anil, you have raised a hand. What do you want to say, ma'am? Unmute yourself. Unmute yourself.
Yeah, can you hear me?
Yeah, yeah.
So, having been in the field of obstetrics for a very long time, let me just remind everybody here that stillbirth is one of the most unexpected events in your practice, especially if she was your own patient throughout her antenatal checkup and she lands with a stillbirth. That is the most traumatic event for an obstetrician to handle. So, the only message I want to convey to this August audience is uh, uh, just be to the point. Yes, we have lost the baby. Don't try to analyze the whole of obstetrics in front of the patient at that time. Neither you will understand nor the patient will understand. Just handle the situation. Yes, it has happened. It's unfortunate. We will look into it. And then, whatever battery of tests have to be done, the onus is on the patient to come back, and the onus is on you to convince them to come back. Because 80% of the times, if they've had a stillbirth with you, they'll not come back to you. So when you give a discharge to the patient, you make note of all that you want done on the case sheet, sign it, stamp it, and your counseling notes also should be mentioned so that no other colleague or other doctor can point fingers at you and take you to court. These are the very common
Vote
court
form.
applications, I must say, where as Madam Divya had said that अरे तुमने टॉर्च नहीं करा था तुमने ये नहीं करा था, so it hold opens up a Pandora's box. We may not have done a torch because the patient had no indication. It was in that 50% category, an unexpected stillbirth. We don't know. So be very careful when you're talking and finishing your chore of delivery at that time. Talk to the minimum, talk with the representative in front of you, talk with the relatives in front of you. Make sure the relatives are real relatives, because sometimes you finish counseling and then one person will come, no, no, I am the actual person you should have spoken to. वो कोई भी नहीं है, उसके साथ क्यों बात करा, मेरे साथ बात करो. So your counseling will go on and on. Be calm, collected, and it's a textbook event. It is not that it has fallen on your head from heaven. It is a textbook event. There are stillbirths in the world, and we are not the only country who is facing stillbirths, and you're not the only obstetrician who will face a stillbirth. So on the medical legal aspect of it, I'm just saying, don't talk too much to the patient at that time about what you're going to do, what went wrong, why it went wrong. Just keep to the bare minimum. Thank you for giving me this opportunity to talk.
Thank you, Dr. Anil, for your kind inputs. Yes, you're very right. We have to be very relevant at that time. No irrelevant talks and no loose talks. Dr. Deepshika, you also raised a hand on you want your comments as well. Unmute yourself.
Uh, can you hear me, Dr. Vadna?
Yeah,
Thank
yeah,
you.
yeah.
First, I'm sorry I can't be expert on ma'am's talk. I am her student for so long years. I can't be expert on that talk.
Expert on your own,
And
yeah. Your
she has
own
explained
inputs.
everything such
So beautiful.
beautifully. Everything she almost covered. And I just thank you, Dr. Neela. And she told so many things. I think no obstetrician is there who has not faced this situation in her practice or in her life. And these days, as ma'am said earlier, also she said, like hypertension, we are able to reduce incidence of eclampsia and preeclampsia is slightly reduced these days. But GDM is increased, and intrahepatic cholestasis, which suddenly the levels rises, bile acids and the IUD occurs. You have got the test done 2 days ago, and sudden the levels are increased, and the sudden IUD is there. So I think nothing is left. Ma'am has told everything, and once the one IUD has occurred, you should be convincing the patient to get everything done before she gets pregnant again, so that we can at least investigate what can be the reason, although it is unexplained most of the times. And I have seen a tight loop of cord also once or twice, and true knot of cord. As I remember, in few of cases, I've seen true knot of cord which was very tight, and once I saw 3 loops of tight cord around the neck. And once I got level 2 when started 25 years ago. मेरे रिलेटिव थे वो पेशेंट, तो मैंने उसको लेवल 2 नहीं लिखा, अपने किसी जान पहचान के अल्ट्रासाउंड वाले के पास भेज दिया, सो दैट शी इज चार्ज लेस, but he will do the level 2. And that IUD occurred later. And they questioned, as ma'am said, they questioned that level 2 was not done. Although it was done, but there was no anomaly also. So we have to write everything.
Right,
We have to write everything so that we are saved.
right.
Thank you, ma'am. Thank you, Dr. Vandana.
Thank you, Dr. Deepshika. Dr. Surekha.
Hello, madam. Madam has really presented everything in such a organized way. I have read so much, but the slides were so organized, so I took all the photographs to keep my material also very organized. Only thing I will like to add is nowadays we do not go for a means just wait for the spontaneous labor. As soon as we diagnose, we try to induce the labor and deliver, because that will reduce the psychological uh, harassment to the parents, and we can easily have a good baby for the autopsy, as because the baby will not be macerated then. And they say that after 48 hours the coagulation starts deteriorating, coagulopathy starts getting up. So as early as we can induce the stillbirth, it is better. However, no deaths occurs from hemorrhage, because they say even if it is deranged, we can fibrinogen is less, plasminogen is less, and then all the coagulation is deranged. Low molecular weight heparin or heparin drip can be added, but we should not go for that, and we should do the early induction. Otherwise, everything has been said so many times. Thank you very much.
Ma'am, what about ART pregnancies? ART pregnancies are also prone to stillbirths.
Stillbirth, more to stillbirth. Early miscarriages there.
Yes,
I
yes,
must
ma'am.
tell you that
They are.
ART pregnancy management is much more difficult, and all ordinary gynecologists cannot manage ART
Yes.
pregnancy, because there you find the early growth retardation, and the fluid becomes less in the amniotic fluid. All that kind of things have to be managed well. You can't ignore it, and you can't have that similar kind of frequency. Has to be of examination, has to be more frequent.
Yeah, Sharda ma'am, I'd like to ask you a question.
Yes.
You said a second, when the patient comes back after a stillbirth to you, don't you suggest that the delivery should be induced at least 2 weeks earlier than the time when she had her
Previous,
stillbirth? Is
previous.
that a point to note?
No.
Very right. In fact, what one has to see is that your investigation and intense monitoring should start at least 2 weeks before.
Hmm.
She's asking
So,
for delivery, ma'am. She's saying we
yes,
should
yes,
use the
I'm asking
delivery.
for
So
delivery
No,
because
अगर
no, no.
35
psychologically,
35
No,
weeks
no.
में still birth है, 35
yeah,
weeks में पहले still birth है, so you have to probably see to it that the delivery takes place early.
yes, the delivery and the baby is kept in a fine union, because as the time approaches, that 35 weeks or 37 weeks of the previous episode, the patient and the family get so stressed out that I'm sure with the stress itself, they'll go into another stillbirth. These
You're
are
right.
practical points. So I think, madam, I'm asking you, can we recommend 2 weeks before the previous stillbirth date a
Strict
delivery? Can
monitoring.
we plan?
Strict
I
monitoring.
think they cannot go beyond that particular date, but one has to see and monitor such patients. But
Yeah,
yes, you have to
agreed,
be very, very
agreed. Yeah,
careful.
You
yeah.
can't give a iatrogenic preterm birth for no rhyme or reason. You have to
You
balance
have to
everything.
have the color Dopplers frequently or NST very
Everything,
frequently,
everything. Yeah,
or
everything.
fetal movement counting.
Archana ma'am, we'll have another topic on that.
Right.
Anticipatory obstetrics. That should be titled anticipatory obstetrics for a good outcome. Huh? अर्चना मैम मैं आपसे बात कर रही हूँ.
Obstetrics is very difficult.
Yeah.
Dr. Archana, you're muted. Dr. Archana, you're muted.
I think she's talking to someone else.
Yeah.
Maybe.
Chalo. Okay, I think,
Okay.
ma'am, you are done. It was so excellent. I
Excellent,
think
ma'am.
you have
Ma'am, I have seen.
given an abstract of chapters from so many books. It was wonderful to hear everything together.
There was I just want to give an anecdote that there was a patient who came after 2 stillbirths. And this was the third pregnancy at 38 weeks. I said, I'll go in for a section. I am not waiting for a normal delivery, neither I'm inducing you. It's your call. They agreed. And I did a section, and the baby had true knot. Although that is not a cause of repeated stillbirths, but in that pregnancy also the baby it was a true knot and double knot, not a single knot. There was a double knot in that.
That was I was telling. I have seen even IUD at 16 weeks, and we delivered her, and we saw that true knot.
True knot
Uh,
was there. नहीं,
true
but
knot was
she
there.
was carrying on turn, and they were expecting कि ma'am induce कर दीजिए. I said, in my opinion, I would not. You have had 2 stillbirths. I am too scared to give you an induction. Frankly speaking, I'll go in for a section. Everything has been going fine with you, and very few antenatal visits.
Yeah,
And
ma'am, I think obstetricians give too many options to the patients. An obstetrician is a
Yeah.
specialist with special knowledge. They should take a decision for the
firm
patient
decision.
and be
Yeah, you
firm
have
on
to
it.
be firm about.
You can't leave these decisions to the patient. You are going to suffer in the end. How is
Yes,
the patient and illiterate person going to cover such a large plethora of knowledge in your head and come to a conclusion? You take the decision for the patient
definitely.
and
That's
said
what I'm
nothing
saying.
doing. This is it. You
Nothing.
want
Yeah,
to
Yeah.
get it done. Otherwise, go elsewhere.
yeah,
Shove them away if
Yes.
they don't agree to your
And
decision.
also
absolutely
document.
right.
If she
Yes.
refuses, document it.
Most of the patient, they don't understand what is altered CP ratio and what is absent umbilical artery flow. Even if you explain them everything, जो उनके बुजुर्ग होंगे वो कहेंगे अरे नहीं
Don't
नहीं डॉक्टर को ऐसे बोल रहे हैं
don't
अपने
explain the
and the
details.
next day they come with the IUD. और फिर जब उनको बोलते हैं तो बोलते हैं मैडम आपने अच्छे से समझाया होता तभी तो हमें समझ में आता.
यानी and ultimately they are going to say डॉक्टर साहब आपको डिसीजन लेना चाहिए था हमें क्या मालूम है. That's the last
Yes.
sentence you
Nahi,
hear
nahi.
from them.
Very
Dr.
true.
Anil, there was a patient who was having severe fetal distress, and her parents-in-law, what they said was, I said, then we are going to lose the baby if we continue like this. तो सर आपको क्या फर्क पड़ता है बच्चा इतनी ही सांसें लेकर आया था. This is then I had to send them away. I
No,
said,
no,
okay, you
I
from here
work
you go.
I work in a predominantly Muslim estate, so they say मैडम कोई बात नहीं और एक हो जाएगा.
Yes, yes, same here. I saw
अच्छा, another
25
point.
years ago one patient who was full term and PET. I told her to induce. Her daughters were 17, 18 years. It was late age pregnancy. So maybe they got sex determined or something. So I said कि induce करना पड़ेगा. तो उन्हें लगा कि मैम तो सिजेरियन करने के लिए तैयार है. तो and 2 days after that they came with IUD, full term male baby.
Male baby. So
हाँ,
such a मतलब उसका bad luck भी खराब था.
bad luck भी खराब था.
So one more point I wanted to add was this, that we normally tell the patient to lie down on the left lateral side. So
Yeah.
this is of utmost importance also. It's very relevant. In fact, it has been seen a number of times that in the supine position the patient has had a stillbirth. तो हमारे को बार-बार उसको left lateral position के बारे में जरूर बताना है.
Madam, let us all agree on one thing. Obstetrics is mysterious, actually. You are sometimes know better than the decision another doctor will make. It's mysterious. You come across sudden events which are beyond your control. What can you do? You have to
Exactly,
just be
No
exactly.
prepared
doubt
how to
about it.
handle it.
Yeah.
You should just have the knowledge
Yes.
that yes, this is a possibility. It's a common or an uncommon possibility, and it's the way you talk to the patient in medical legal terms that will save you from a lot of difficulty.
Absolutely.
Yeah.
जब भी
Thank you,
कहीं
ma'am.
प्रॉब्लम हो
Thank you,
Thank you,
Archana.
Dr. Ma'am.
Thank you, Archana. Thank you, Sharda, ma'am. May I leave?
Great.
Somebody
Definitely,
is at my door. Yeah.
Beautifully
Thank you.
summarized
Thank
and
you, Dr. Anil.
organized.
Thank you. Thank you very much.
Yeah.
Thank you,
Thank you,
ma'am.
ma'am.
Take
Thank
care.
you, ma'am.
Take care of your health, ma'am.
Yeah.